May I now request Dr. Akshay Nair, who is the visiting consultant and oculoplastic surgeon at Sion Hospital, Lokmanya Tilak Municipal Medical College and General Hospital, to please make his presentation. We are expecting you, Akshay, to answer a whole lot of questions about whether to remove the eye or not to remove it. So looking forward to your presentation.
Right, ma'am. I hope my audio is loud enough.
Yes, your audio is loud enough and we can now see your screen as well.
All right. So thank you, Dr. Bradu, for this opportunity. I think the holistic approach to mucormycosis is something that all of us have been, looking forward to. And especially the talks by Dr. Anaga and Dr. Kshitij were very enlightening. At the outset, this is a currently evolving scenario. The handful of cases that we've seen before COVID and now that the amount that we are seeing, it's in many cases it's a life-saving situation. So we are treating the disease as we see it. What I present is our understanding at present, and it is possible that these concepts may evolve, they may change, or remain the same as we go ahead. These are a couple of slides that from a paper that I saw, which looks at the post-acute sequelae of COVID-19. These are 75,000 patients who had COVID in 2020, and at 6 months follow-up, they were evaluated and they saw that the new onset diabetes was seen in 8.8 per 1,000 patients. Increase requirement of insulin was seen in 5 per 1,000 patients, and increased oral hypoglycemic dosage was seen in 5 per 1,000 patients. So similarly, there is now evidence to show that the COVID virus itself affects the beta cell in the pancreas. So COVID, the virus itself is known to be, we suspect to be diabetogenic, which is possibly what is contributing. So it's easy to, put the noose around the neck of steroids, but I suspect it's multifactorial. We still don't know the role that each of these things are, playing. But at the end of the day, what we know is that, there is severe local and systemic immunosuppression, which leads to mucormycosis in the nose. And at the outset, we know it is rhino-orbital, or I prefer to call it sino-orbital, as I talk about it later. And the orbit is right next to the nose. And hence, given the anatomical location, it's easy to see why the disease can spread so easily. So typically in the ophthalmology department, we can see them either early, late, advanced, and there is a possible role for a staging system that has been proposed. So this is what, the ophthalmologists are proposing. There is a staging system. It says that, stage 1 and stage 2 should be involvement of the nose and the sinuses. This really isn't our domain, so I won't talk more about it. This is where we, focus in the involvement of the orbit, where depending on how much of the orbit is involved, we then decide what needs to be done. This is how a typical patient usually we see presents to us. There is ptosis, there is complete drooping of the eyelid. There is proptosis, slight, and frozen globe or ophthalmoplegia. And we see in advanced cases, there is loss of vision. So why does all of this happen? This is because, it is an angioinvasive disease that gradually affects each structure within the orbit as it goes to the apex. This is a spectrum of presentation. You have mild ptosis here. You have complete total ptosis over here. Then, you can even have severe proptosis with orbital infarction here. Here, there is a globe that has perforated. You can see that clearly here. There, you can see there's a perforation here. And this is the black necrotic eschar that you're seeing, and which is why colloquially we have the name black fungus. So there is a variety of presentations with which the patient can come to the ophthalmologist, but this and this are the most common presentations that we are seeing. Also vision loss. We are seeing a lot of patients coming directly with vision loss and some amount of motility disturbance and ptosis. Now, why is there central retinal artery occlusion? Typically, central retinal artery occlusion that we as ophthalmologists are seeing is embolic, where there is, a cholesterol embolus or an atherosclerotic, because of an atherosclerotic process that goes into the central retinal artery here, which is a direct branch of the ophthalmic artery. But in this case, in mucormycosis, this is an angioinvasive disease. So if the ethmoidals are involved, from here, there is direct extension of the mucus, of the mucormycosis, of the fungus that invades the optic nerve, the vessels here, and that causes occlusion of the central retinal artery. So this is not a typical occlusive disease because the central retinal artery comes off at this level. So if there were an occlusion anywhere along this, that would mean that the disease has already reached the apex, which is not the case. So what does the ophthalmologist have to do? This is typically what they would have to do in any patient, but more so in a patient with mucormycosis. Do a thorough vision check, assess the motility and photograph it, check the pupils and document them, evaluate the fundus or the retina. An optical coherence tomography or a fundus fluorescent angiography is needed, especially if there is central retinal artery occlusion, to document it so that, at the end of the day, the decision depends on whether you're going to exenterate or not. Exenteration is a form of amputation. It's a mutilating surgery. So you need to medico-legally have everything in place, which is why you document your findings and keep a copy with you. So what do we have in our armory as an ophthalmologist? We have three options. There is orbital debridement, there's orbital exenteration, and there is an evolving addition in our armamentarium, which is transcutaneous retrobulbar injection of amphotericin B. So I'll talk a little bit on exenteration because that is our go-to, given that most of the cases that present to us are severe cases with profound orbital involvement. Exenteration is our go-to surgery as orbital surgeons for mucormycosis. So in indications for exenteration, literature tells you that there is no standard of care because there is no guideline to tell which case you should exenterate, which case you should not exenterate. This is what literature traditionally has said. And there is a reason why they say that. Because if you look at most of the other papers, they say that exenteration did not affect the patient's survival. But you need to take this with a pinch of salt, because in these cases, they are anyways performing an exenteration only when there is progression of disease to the intracranial fossa. So in this subset of patients where disease has already reached the brain, we know that any exenteration or any intervention is not going to change the outcome or the prognosis. What we are interested in is the role of exenteration, when to do, and what stage is exenteration indicated in orbital disease, not disease that reach the brain. Exenteration itself is a radical surgery. As you can see, we are removing the entire contents of the orbit, leaving nothing behind. And to echo what Dr. Kshitij said, the aim is to reduce the infective load by removing the orbital contents, and also by making sure that the orbit is no longer the source of any further infection that spreads intracranially. So in many ways, it's source control. Why are we doing it? Because by removing the necrotic material, we are allowing more amphotericin B to reach the edges of where the infection were. Also, in cases where there is threatening intracranial extension, such as orbital apex involvement, there you would want to make sure that you are able to exenterate right up to the apex so that whatever disease was there in the orbit doesn't spread beyond. And in cases where there is already established intracranial extension of the disease, there is we are on the fence here whether really exenteration needs to be done, because as I said, it may not change the outcome, it may not change the prognosis, but there is some evidence that can increase the survival. And in these patients, who are post-COVID, survival for a few more days may be of some value to the relatives. So when do we exenterate? There are clear, easy indications. When there is a deformed globe, gross hypotony, gross intraconal infiltration. Now, intraconal basically means that there are 4 recti muscles, the superior rectus, inferior, and medial and lateral rectus. As they go posteriorly, they form a cone. That intraconal space is the space that is in between the 4 recti muscles, through which the optic nerve also goes. So intraconal is this space. Anything outside this muscle cone in the orbit is the extraconal space. Now, before we do anything from our side, all of us know that the primary treating clinician for orbital mucormycosis or rhino-orbital mucormycosis is the ENT surgeon. So without endoscopic debridement, which is aggressive, like Dr. Kshitij said, without systemic amphotericin B, and without strict diabetic control or tackling the immunosuppressive factor here, everything that the ophthalmologist will do alone cannot help. So this is a true team effort. And which is why we need to make sure that all of these three are happening simultaneously, because each of these, in any one of these, if not happening, can undermine the efforts of the entire team. So basically, why are we looking to remove the necrotic material? This is angio-invasive disease, mucormycosis. It occludes the small and medium-sized vessels, it invades them, causes occlusion, and therefore the area that is supplied by the blood vessel is then ischemic, undergoes necrosis, and there is tissue damage. And because there is necrosis because of occlusion, any amount of amphotericin B that you're pumping in will not reach that area where there is necrosis. Therefore, we have to literally remove it. This is also the rationale behind directly giving amphotericin B to the orbit in the form of retrobulbar injection. Because we know this is angio-invasive, we know amphotericin B systemically may not reach there, so we can actually push the amphotericin B there directly through the orbit and hope that it works. So how do we know when do we exenterate, when do we debride, and when do we give retrobulbar amphotericin B? For us, we need to identify that on the basis of MRI with contrast. And I'm really glad that Dr. Anaga explained that so beautifully with those examples. As a rule, loss of vision, presence of ptosis, and ophthalmoplegia are not indications for exenteration. These three things, any one of these things alone is not an indication for exenteration. So what is? So we look up to radiology and ENT. From radiology, what we want to know is there loss of contrast transmit in the extraocular muscles? Is there orbital apex involvement? And what is the cavernous sinus status? This, when we get from a radiology, is important, which is why the team involves the radiologist and not just the ENT, the ophthalm physician, and the microbiologist or the pharmacology and pathologist. The radiologist is a very important key member, because if there is only mild or subtle enhancement in the adjacent sinus area, we do what is called TRAM, transcutaneous retrobulbar amphotericin B. If there is moderate or diffuse enhancement, we still go ahead and do TRAM. Only when there is loss of contrast enhancement, which we know that when we are injecting contrast during an MRI, loss of contrast enhancement means that the contrast is not reaching the structure, which means that devitalization or ischemia has set in. And in extraocular muscles, there is edema, which is increase in size of the muscle. Then there is edema with loss of contrast enhancement. And then there is finally complete distortion of the extraocular muscles where you're not able to make out what they are. So based on the amount of contrast that we see, we decide whether to go in with conservative debridement or retrobulbar amphotericin B. If there is diffuse loss of contrast enhancement or at the apex, then we will consider exenteration. So this is like a management algorithm that we consider. Now, this is a CT scan like Madam had mentioned. It shows sinusitis. There is gross orbital infiltration over here. Similarly, there is apical infiltration. Here, we would not think twice before exenterating. Now, this is an MRI, which is post-contrast. Now, you can see that, compare this medial rectus and compare this medial rectus. There is slight, the size is almost the same, but there is clear, reduction in contrast enhancement, but there is still contrast reaching there. So in this case, we would still try to give retrobulbar amphotericin B for a chance for it to work. Now, as Madam said, now here you can see clearly the black turbinate sign. The turbinate should be seen, but that is not being seen here. Compare this medial rectus, compare this medial rectus. This is a normal slit-like medial rectus. This is thickened and edematous. Not only that, there is loss of contrast enhancement across all four recti. This is an orbit that I would like to exenterate because amphotericin B is never going to work there. Similarly, now in this eye, you can see that, okay, I'm gonna go back. Yeah. In this patient, this area, here you can literally see a dying medial rectus. The medial rectus is there. There is so much loss of contrast enhancement, and one little sliver of area is getting contrast. And here, the medial rectus, the superior oblique, the medial rectus, and part of the inferior rectus were what was involved. We went ahead with an exenteration, and you can see that the medial rectus and the inferior rectus, this is the necrotic part that was exenterated. This is the healthy fat tissue in the superior part of the orbit. This is the optic nerve. So clinically, there is a pathological correlation with the radiological findings, which is why we look to radiology. Here you can see this medial rectus, there is loss of contrast enhancement in this medial rectus. Of course, there is also dural enhancement in the frontal lobe, which suggests there is intracranial extension. Now, like Dr. Kshitij said, this wonderful scoring system that they have developed, which we are now in the process of validating, we were looking at clinical symptoms, ophthalmic findings, and imaging. And based on each of the findings that we see in vision, pupil, motility, proptosis, and the ophthalmic findings in terms of cotton wool spots, vessel occlusion, retinal detachment, choroidal folds, and optic disc pallor. This is a stepwise pattern because that is the gradual progression of how compressive ophthalmopathy will present. And also imaging is important. Now, all of these, like Kshitij said, has a score of 45. Anything above the score of 23 needs to be exenterated. And we are in the process of validating to show that this holds true even in the post-COVID phase. I'll quickly run through a video to show what we do in exenteration. Now here we are doing a lid sparing exenteration. It's a little different from what Dr. Kshitij mentioned, but the eventual outcome is the same to debride the orbit. We've tied the lids together, which is a tarsorrhaphy, and we are sparing the eyelids. So we go in a suborbicularis plane to reach the orbital rim. And once we expose the bone and the periosteum, we make an incision on the periosteum and then elevate the periosteum all around. So here we are incising the periosteum with a monopolar cautery. And once the periosteum is incised, we elevate it along the edges all across. There are a few important structures, the lateral canthus, then there is the temporozygomaticofacial, the zygomaticofacial, the zygomaticotemporal vessels. Then of course, here you have the supratrochlear and the supraorbital over here, and the nasolacrimal duct over here, which is cut. Once that is cut, we elevate the periosteum from all around, and then we go ahead and make an incision posteriorly. We go and cut the orbital apex, depending on the amount of clearance that we need. Now here, we didn't need complete posterior clearance because this was not for mucormycosis, but typically we would want to reach the apex and debride all of this tissue as well to make sure that we leave behind bare bone and nothing else. This is then sutured together. The lids are then sutured together depending on the vascularity that there is. But of course, in many cases, we see flap necrosis that begins like this and then eventually ends like this. This way, then we allow it to heal such that the skin epithelializes, or some cases needs a skin graft. Be careful not to put any graft over it, such as an anterolateral thigh flap or something of that sort. These are dead avascular beds which has angioinvasive fungus in it. So graft is never going to take up. So an exenteration is to be performed only when needed and decide on the basis of evidence. Radiological evidence is needed. Now, debridement is an option, which means that if there is only a focal area medially in the orbit, it is in the extraocular muscles are involved, or the orbital fat is involved in the form of fat stranding. Along with your ENT surgeon, when they go and do a endoscopic debridement, you can ask them to open up the lamina papyracea, the medial wall, and then combined, as Dr. Kshitij said, you can debride the devitalized tissue. But there is only a certain amount of debridement that you can do. If the entire orbit is involved, you cannot debride the entire orbit and leave behind the globe. It is a non-viable globe, which cosmetically will not be viable. Also, postoperative fungals and postoperative imaging, antifungals and postoperative imaging, extremely important. So then comes to the third, which is retrobulbar amphotericin B. When do we give? We give it in cases when there is good vision involved, or there may be even mild or moderate vision loss. Radiological involvement of the orbit, which is not amounting to any exenteration, and the orbital apex uninvolved. Extremely rare is when the orbital apex is isolatedly involved, such as spread through the pterygopalatine fossa into the apex, not through the anterior orbit to the posterior orbit. In these cases where there is isolated orbital involved with salvageable vision, we would give a trial of retrobulbar amphotericin B, and then be very, very cautious that at the earliest sign of progression of disease, you'd want to go and exenterate. There's very limited evidence, but still we are giving it a try. There are literally 3 case reports on the basis of which we are using retrobulbar injection of amphotericin B for mucormycosis. But actually, there is a lot of other evidence for retrobulbar injection that comes from aspergillosis. Not so much for mucormycosis yet. We are going ahead because this is, in many cases a life or death situation, but we should know that it's an off-label usage, and we have to be very selective in the cases that we choose to work. Now, this was a patient who came, 65-year-old male, previously operated. The right eye already had complete loss of vision, and this time the left eye was involved, total ptosis, mild proptosis, and ophthalmoplegia, 624 vision in the left eye. Now, imaging was done. You are seeing that the muscles are thickened and there is intracorneal fat stranding. You can see that there is some amount of medial orbital disease, but the money is where there is contrast. There is good contrast uptake. So which means that systemic amphotericin will be also working here. In this case, along with systemic amphotericin B and ENT colleagues having to debride the orbit, we gave retrobulbar amphotericin B, which is 1 ml containing 3.5 ml or 3.5 mg of amphotericin B, given in the quadrants that are radiologically involved. It is freshly prepared amphotericin B given daily or on alternate days up to 5 doses. And at the 7th day following the last dose, we repeat imaging to see the improvement. And in this case, we could see that the ptosis and ophthalmoplegia had resolved completely to give a very good satisfactory outcome where we could spare the orbit. So TRAMP, of course, is needed only can be done in patients where you have the facility to keep repeating MRI to see the progression of the disease or the response to treatment. Remember, their complications are also possible. This is orbital compartment syndrome following injection of amphotericin B. So we don't always exenterate, and the old adage that exenteration must immediately be performed in a diffusely inflamed orbit is no longer true. We can wait and watch and look for the systemic response to treatment. When we debride the tissue, vascularization is key, because when we see bleeding, we know it's healthy tissue and we can leave there. Also a suggestion to, add amphotericin B injections into the orbit when you debride the sinuses. Sometimes we are seeing atypical cases that are literally turning our concepts upside down. This was a gentleman who, typically we know that it invades it usually invades from the medial side of the orbit, but here we can see that the inferior rectus is involved. And we know that first stage, initially we see nasal eschar and crusting in the nose, but the endoscopy here was suggestive more of sinusitis with otherwise healthy vascular mucosa. Similarly, another patient with diffuse orbital involvement. Here you can't even see the outline of the extraocular muscles. Barely involved perineural enhancement of the optic nerve. But again, the nose showed just hyperemia, no eschar. So there are typical atypical forms, but where you need to be aggressive and not wait for progression. At the end of the day, the ENT surgeon leads the team, and we are happy to follow aggressively, operate wherever indicated. But in our experience, we are seeing a higher proportion of cases where there is orbital involvement, aggressive sinus debridement, amphotericin B, and reversal of diabetic status or immunosuppression are equally important as compared to, along with ophthalmic surgery. MRI with contrast, I would never operate an eye without an MRI with contrast. A CT, deciding whether to go into the orbit or not based on the CT scan is suboptimal. So that is something I'd like to harp and underscore. One treatment plan doesn't fit all. We need to customize and treatment plans, and not all blind eyes need to be removed. The removal of an eye can be psychologically devastating for a patient. So we try to salvage the eye, but not at the cost of losing a life. And there are success stories. Mucormycosis has high fatality rates, but we are also having patients who have undergone mutilating surgeries and come back to us healthy. Thank you.
Thank you so much, Dr. Nair. That was I think it has comprehensively answered the question that I put to you at the beginning of the talk, that please let us know when and when not to remove the eyeball. I'd just like to let you all know that there's been a tremendous response, and there are a whole lot of questions which have come up.